Good afternoon. My name is Iro Mukturi, and I would like to welcome you all to the third session of Breast Radiology Innovation course. In this session, we're going to talk about breast MRI imaging, which is mainly used for screening women at high risk for breast cancer, to determine the extent of cancer after a new diagnosis, to evaluate difficult problems found in mammogram and ultrasound scans, to evaluate lumpectomy sites following treatment and response to neoadjuvant chemotherapy. It is my pleasure to present our next speaker, Dr. Panizza Pietro, who is a radiologist, head of the breast imaging unit in Ospedale San Raffaele Scientific Hospital in Milan, and here to talk to us about dense breast and the value of MRI. The floor is yours, Dr. Panizza.
Thank you very much for the invitation. Thank you to the coordinator. My topic is dense breast. I have to speak about the added value of MRI. Okay. Just a second. Okay. This presentation is sponsored by Bayer. And just to remind you, that the American College of Radiology divided in 4 categories the density of the breast. On your left, you see the EDA category, that is a fatty breast, and in your right, you see the D category, that means extremely dense breast. And they calculated that about 10% of the screened women have an extremely dense breast. It's 8%, quite the same for the Dutch screening. So breast density is an implication for both breast screening and risk. And dense breast is also an independent risk factor for the development of breast cancer, but it obscures, as the radiologists know very well, obscures cancer as a mammogram. It is still a big problem. It's interesting to look at this, at the results of this meta-analysis from McCormack that's correlated the percentage density with the relative risk. You can see that the risk is 1.79 in case of a very fatty breast, increasing to 4.64 in case of in extremely dense breast. They concluded that the dense breast is one of the strongest risk factors for breast cancer. Concerning sensitivity, there is an agreement between the authors that the sensitivity is very low. The sensitivity of mammography is very low in case of fatty breast, around 62%, and is higher, obviously, in fatty breast, is ranging around 88%. Another problem correlated with breast density is the interval cancer. You know, the cancer comparing between the different rounds of the screening, because the interval cancer rate in case of a highly dense breast is 28%, compared with the 7.2% of screen detected cancer, or 5% in case of healthy controls. And the authors concluded that up to 22% of the interval cancer might be prevented if adopting a special screening regimen in subjects with extremely dense breast. Again, Wurtzenberg on this paper demonstrated that, confirmed that the sensitivity of mammography decreased dramatically in case of dense breast. And the question is how to increase the sensitivity of our examination. We have 3 techniques: tomosynthesis, MRI, and ultrasounds. We can evaluate the performances of those techniques, except MRI, because I will speak about it. But we can look at the results of the Wurtzenberg study that concluded that digital breast tomosynthesis is less effective in women with extremely dense breast. Breast ultrasound detects additional early stage invasive cancer when combined with mammography. However, this technique has a relevant limitation, and you know the most important is the operator dependence. And then we can consider the MRI, but it's an expensive examination. So we have to think of abbreviated MRI protocols to reduce the cost and increase accessibility to the women with dense breast. So this table summarizes very well the situation that if we look at the 1,000 women screened, we expect to find 2 to 7 cancer for 1,000 women. If we look at 2D mammography, if we use mammography plus 3D, I mean, you use tomosynthesis, we increase the number to 3 to 9. Using ultrasound plus 2D mammography, we increase the number of cancer detectors to 4 to 11. And there is a dramatic increase if we use MRI, because we can add about 10 or more additional findings. And in the total, we can find, we expect to find from 12 to 17 cancer that we have to compare with the 2 to 7 cancer we can find using the 2D mammography only. On the other end, you have to consider the women called back, that is 100 for the 2D mammography, decreasing to 70 using tomosynthesis, but increase dramatically in case of ultrasound and MRI, because it's, the recall back is ranging from 170 to 230 for ultrasound and MRI. Let's see some cases where the added value of MRI is very important. There is an important impact of MRI in case of dense breast. There are preoperative local staging, adjuvant therapy monitoring, and screening. In case of preoperative local staging, you can just this image to show you how is important the MRI. You have an extremely dense breast. There is a huge palpable lesion on this breast. You can't recognize it with mammography. You can easily recognize it and dimension it with the MRI. And again, in preoperative local staging, in this case, you can recognize on the left breast in the upper quadrants, thanks to the focus on microcalcification, a cancer that is well visible at MRI. But MRI, you can also recognize some additional small foci, small cancer, satellites to the index cancer. And you can also find a small cancer in the contralateral breast. This study demonstrated how the density is important when you have to decide if perform or not an MRI before surgery, demonstrating that in case of radiotransparent breast, the sensitivity of MRI and mammography is quite the same. But if we look at the middle density or dense breast, there is a big difference, 20% of difference, 60% is the sensitivity of mammography, 81% the one of MRI. An example, an extremely dense breast, bilateral dense mammography, and in this patient there was a palpable highly suspicious lesion on the lower inner quadrant. Mammography was negative, ultrasounds were negative, but so I performed a core biopsy on the highly suspicious palpable lesion, and the response of the pathology was invasive lobar carcinoma, so we performed the MRI, and you can easily recognize the lesion on the right breast, and you can dimension it. And at the same time, we found another lesion on the contralateral breast and not visible at mammography, not seen at the previous ultrasounds. It was another invasive lobar carcinoma. The literature demonstrated on these guidelines, there is a recommendation concerning the dense breast in a preoperative setting. They recommend a breast MRI in case of dense breast, and they strongly recommend a breast MRI in case of patient with an histology of invasive lobar carcinoma, especially if the breast is dense. This study is very interesting. It's the GEMMA study. We have two studies, 1 and 2 GEMMA study, because it's a study, the aim of the study was to evaluate the capability of the two techniques, the sensitivity of the two techniques to in detection of the index cancer in a preoperative clinical setting. As you can see, the sensitivity of MRI was independent of the degree of breast density. Examining the fatty breast versus extremely dense breast, you see that in GEMMA 1 and in GEMMA 2, the sensitivity of MRI was the same in fatty breast and in dense breast, 83 versus 83% in GEMMA 1, 91 and 91 in the GEMMA 2. The sensitivity of mammography declined. I mean, as we can expect it. In GEMMA 1, the sensitivity in fatty breast is 79%, in extremely dense breast is 62%, the same in GEMMA 2, confirming that there is a decrease in sensitivity in the extremely dense breast. So we have to take into consideration those results when you have to decide if perform MRI or not in a preoperative patient. Also, talking about recurrence, it's important to perform the breast MRI in case of dense breast, as demonstrated in this study, because they demonstrated that breast MRI, preoperative breast MRI can reduce the risk of recurrence in patients with early stage triple negative breast cancer. The same example I showed before, talking about neoadjuvant therapy. I don't need other words, just you can look at the examination and you can understand how is the difference. I mean, you can recognize the lesion on the dense breast at mammography. You can't measure because it's a huge lesion. You can measure it with ultrasound. You can recognize very well the lesion. You can measure it with MRI, and very important, you can evaluate very well the response at the end of the treatment, as you can see in the MRI image, in the lower MRI image. And you can monitor the response to the therapy in a breast like this with mammography and ultrasound, as you can see. You need absolutely the MRI. Talking about screening, Christiane Kuhle in 2017 demonstrated that additional MRI imaging can find additional breast cancer with a supplemental cancer yield of 15.5 per 1,000 cases. And she also demonstrated that the cancer diagnosis with MRI were small, node negative, and high-grade lesion. And another important information is that in that study, the interval cancer rate was 0. And this is to introduce this very important trial, the dense trial from the breast community of the Netherlands, that is still ongoing. I have to thank Skylar Gills, that is an epidemiologist, one of the authors of this paper, and one of the people studying in this protocol. They evaluated the role of the additional MRI screening in women with extremely dense breast, and they obtained just the first round significant information that I think will change our approach to the screening of dense breast. The selected patient were patients with, the participants were patients with extremely dense breast and a negative result at mammography. So dense breast and negative mammography, they have been randomly assigned to undergo additional MRI or to be treated according to current practice. The study consists in 3 consecutive screening rounds, and the primary outcome is to evaluate the difference of interval cancer between the study arms. And the secondary outcomes is to evaluate the number of MR imaging screening detected cancer, the portion of false positive, and so on. But let's see the results. They enrolled 40,000 patients, and 8,000 patients were invited after the randomization, were invited to the MRI. 4,783 participated, the 59%, 3,278 do not participate, do not accept the invitation to undergo MRI. And then when they started in a control arm of 30,300 women. The results, as I told you, 4,783 patients, 454 were recalled, 300 underwent biopsy. They found 79 cancers. I want to remind you that the mammography, the criteria of the entrance in the study was to have a negative mammography. So they found 79 cancers, 64 were invasive. And I want to underline the difference in detection rate, because in this study, the detection rate, thanks to MRI, was 16.45 versus 6.8 per thousand. So the 6.8 per thousand is the normal detection rate they found in a Dutch biennial mammography screening program. We have to see also, to look at also the false positivity. The number is high, 78 with the MRI per 1,000 women examined, in comparison with 24 per 1,000 in a Dutch biennial mammography screening program. But I have to tell you that the false positive number decrease in the other rounds, because you can compare the images with the previous MRI. And again, another very interesting result is the one concerning the interval cancer rate, that in the women who participated in the MRI program is only 0.83 per thousand. In the arm population was 4.98. So a dramatic difference between women who underwent MRI and the women who underwent only mammography. And this is confirmed also from the rate of women, of the 3,000 women who decided not to accept the invitation to undergo MRI. You see the interval rate in this case was 4.88. So a very good results. Also, if you look at the cancer rates by stage for 1,000, you see the percentage of a T0, T1 identified with MRI on your left, in comparison with the T2, that they are very few. And then, as I told you, they found 4 interval cancer in the MRI population. If you look at the control arm and the population of non-participants at the MRI program, you see that the number of T0, T1 is quite similar to the one of T2. So you have also, it's confirmed the advantage of using MRI also in the stage of the cancer you find. Again, after the second round, done only at the moment with mammography, we are looking only at the results with the second round with mammography. We are waiting for the results from the second round with MRI. you can see that the detection rate of the screen detected with mammography in the population of MRI participants is much lower than the control arm, and then the population of women who didn't accept to participate to the MRI evaluation. So they concluded that supplemental MRI for the previous results, because we are at the beginning. I told you those are the results after the first round. We need other 2 rounds, but now we can say that supplemental MRI screening in women with extremely dense breast results in an earlier stage cancers and fewer interval cancers than a screening with mammography alone. And as I told you before, we are to think about it. The suggestion is to concentrate our attention on the abbreviated breast MRI, and this paper from Ritzman and Christiane Kuhl can help us, because they demonstrated that ultra-fast protocol can have the same performance than the full diagnostic protocol. So with few acquisition, they have the same results as in a normal protocol, including T2 acquisition, diffuse weighting imaging, and so on. And they also demonstrated another interesting thing, that the early detection of cancer with MRI seems to translate into survival benefits. And I think at the end, we will find also, it will translate also in a reduction of mortality. So I thank you very much for the attention, and I'm ready for your question. Thank you.
Thank you very much, Dr. Panizza, for
So I can't hear you.
Okay. Sorry, can you hear me now? Yes. Can you hear me? Can you hear me? Yeah?
Yes, we can.
Okay. Well, thank you very much, Dr. Panizza, for your lovely detailed speech. We use MRI scanning, so we have seen all the good it can have in breast imaging. The cost of the MRI scanning is high, and therefore it would be difficult to incorporate them in a yearly plan. So to manage the associated cost for screening, would there be a role in the use of an abbreviated protocol, and maybe for the high-risk patients?
Yes, so some studies demonstrated that breast density and other risk factors are an indication to the breast MRI. But I think those results demonstrated that you can spend money, but you can save lives. So we have to convince politicians that is something useful. And now I saw you talk about the CHESMA, I mean the contrast media in mammography. I don't think there are numerous experience on this topic. Could be in the future, could be helpful. But at the moment, we can talk just about MRI that we use from 20 years, and the results are very interesting. So I've been very impressed on this study, on this Dutch study, the first results.
Maybe MRI techniques such as diffusion weight imaging, and maybe with no use of IV contrast, could be the future for breast MRI imaging? That's a question. Just
yes, I hope so. Okay. I mean, also because I'm always saying that, for instance, I was talking with Eusobi advisor board yesterday about dense breast. The big problem is that screening in Italy, for instance, we don't say to the women that they have dense breast and that there is a limit. It's not the same in all the countries, in the countries of Europe or United States and Canada. But I think it's becoming an ethical problem because women expect to the screening to know if they have a cancer or not. But the interest of screenings is only to reduce mortality. It's something different. It's different to explain to women. But it's becoming a very important problem. It's an ethical problem. So there was a site on web, I don't know if you know it, from Nancy Capello, Are You Dense? That worked very strongly on the United States, and they convinced all the states to communicate to women undergoing screening to communicate the grade of density and the limits of dense breast. Otherwise,
yeah.
so it's not correct for the women, I mean. Right? And
I agree. I agree.
think MRI can say the future, can write some more, because we continue to consider MRI something new. We started MRI about 25 years ago, and we are continuously learning things and how to use it, because there are also new topics to use MRI, as for instance, the problem solving is a fantastic technique to solve problems you have with, and the nice thing of our job is to integrate imaging, to be able to move from one to the other technique and to solve the problems. So,
yes, you need to have them all, though. You need to.
Yeah.
Thank you so much for your lovely speech. It was an honor to have you here.
It's a pleasure for me.
And maybe we'll see you again in the future. We will.
Thank you very much.
Okay.
Thank
you very much.
Thanks a lot.
Next, I would like to invite Dr. Pulu Lukia, who is an MRI and CT consultant radiologist at the Aso Maternity Hospital, and here to speak to us about MRI preoperative surgical planning in DCIS and infiltrating breast carcinoma. The floor is yours, Dr. Pulu.
Good morning. Thank you for the invitation. It's okay? Can you hear me? Can you hear me?
Yes, we can. Yes, we can.
Okay, thank you. So the subject of my presentation today is the use of MRI as a preoperative method of surgical planning in DCIS, as well as infiltrative breast carcinoma. According to the European Society of Breast Imaging, USOBI, the breast MRI indications are 10. The first 5 are of extended consensus and are with no doubt evidence-based indications. They include screening in high-risk women, differential diagnosis of a post-operative scar and cancer recurrence, occult breast disease, virus-free lesions in the previous breast MRI, and post-neoadjuvant therapy. The next 2 indications are of limited consensus according to USOBI, and include equivocal lesion in ultrasonography and mammography and preoperative surgical planning. The next 3 are of no consensus, and they include nipple recharge, inflammatory cancer, and male breast. What the surgeon expects from imaging and from a radiologist. The surgeon, first of all, needs to decide if he should operate or not. That this means if he has to perform an open biopsy of the lesion, or if he has to follow up the lesion. This question is answered with BI-RADS assessment categories. We all know that BI-RADS 3 category includes lesions that are probably benign and need to be followed up. And the BI-RADS 5 and 4 categories are lesions that need to be biopsied. A similar classification of corneal results is that of corneal biopsy of histopathology, and there are lesions that are characterized as B4 and B5 that are suspicious or malignant, but there are lesions that are characterized as B3, lesions of a certain malignant potential. Lesions such as sclerosing lesions or papillomatosis or atypical atypia or proliferation. The second question that breast surgeon needs to know is needs to decide is when to operate. That means to operate before or after chemotherapy. Nowadays, after trials, there are results that say that overall survival is the same for adjuvant and neoadjuvant chemotherapy. Neoadjuvant therapy increases breast conservation rates, but may be associated with a low increased risk for local regional recurrence. Also, complete pathological response after neoadjuvant chemotherapy is of increased association with survival. And neoadjuvant chemotherapy is nowadays for triple negative and HER2 breast cancer a first choice, as well as some hormone positive cancers and inflammatory cancer. This is an example of a woman with a lesion in her right breast that is larger than 2 centimeters. And the patient had a second lesion in her right breast. So the disease was multifocal and multicentric. The patient, after biopsy, found that the lesion was an NST grade 3 cancer, ER negative, PR negative, and HER2 positive with a Ki-65 of 60%. And the lymph nodes were positive. After chemotherapy, a follow-up MRI was performed where no lesion was observed. So there was a radiologically complete response. After mastectomy, there was a pathologically complete response also. A second example of a woman with a lesion on her right breast. Next to this lesion that was about 3 centimeters of diameter, there was another lesion that was linear. The biopsy revealed a grade 3 neuroendocrine tumor with synaptophysin positive, with ER positive, PR 5%, Ki-65 60%, and HER2 negative. After 3 months, I believe, 3 months of 6 months of chemotherapy, a follow-up MRI was performed, and there was a residual tumor on the right breast of about 1.2 centimeters, but the linear lesion was the same approximately. After a partial mastectomy, the lesion was a remnant of 1.3 centimeters, and the lesion next to it was some atypia. Another example of a large lesion that has ulceration. The woman has taken chemotherapy, neoadjuvant chemotherapy, and after 1 month, the lesion revealed to be smaller, but a small focus of enhancement was next to it. We considered that this was a remnant from the larger lesion, but after 3 months, a second lesion was revealed there. So there is a recurrence during the chemotherapy that is a bad prognostic sign for the woman. The third question is the type of operation that the surgeon should perform. The question is to perform a breast conserving surgery or a mastectomy, and the sentinel node biopsy or axillary dissection. Nowadays, mastectomy has given its place a local excision, and axillary lymphadenectomy at sentinel node biopsy. Maybe in future we will see no surgery at all. Breast conserving surgery, it has 1 to 1.5 risk per year for 15 to 20 years for local regional recurrence and or contralateral lesions. And but mastectomy versus breast conserving surgery and radiotherapy has the same recurrence rate and overall survival, as well as a sentinel lymph node biopsy in clinically node negative patients is more accurate than axillary dissection for a staging procedure. It is also associated with considerably lower morbidity. The informations for the surgeon from the imaging are the tumor size and extent of the disease, if the disease is multifocal, multicentric, or diffuse, the position of the lesion, and especially the distance of the lesion from pectoralis muscle, and the involvement of nipple and areola. There is a rate of occult nipple areola complex infiltration of 11.3%, but in these situations, even if imaging is negative, a pathological evaluation of the breast tissue behind the nipple is necessary during the operation in order the surgeon to decide whether to reserve or not the nipple. Also, very important is the connection of the lesion with the skin. On the other hand, lymph node evaluation is better with ultrasonography and fine needle aspiration, and is necessary if a positive lymph node is found to put a marker in order after neoadjuvant chemotherapy, the surgeon to know which infiltrated lymph node was emphasizing. This is an example of a lesion next to the pectoralis muscle with infiltration of the skin. The lesion, although it was relatively small, because of its position and infiltration was difficult to be excised, so chemotherapy was given, and in follow-up MRI, a better, less infiltration was observed in order the lesion to be operated. This is another example of a cancer below the nipple. The cancer was about of 1.8 centimeters and had projection, linear projection in the mammography and ultrasonography. An MRI was performed in order to understand the relationship of the lesion with the nipple. Also, some projections were observed, but in this case, it was necessary to perform biopsy of the breast tissue behind the nipple in order to decide during the operation, in order to decide whether to reserve the nipple or not. For a staging method, the MRI is the most accurate method for the evaluation of the cancer extent. Finds ipsilateral unknown disease in about 20%, contralateral cancer in 5%, and identified with ultrasonography, mammography, and clinical evaluation disease in 16%. Change of operation is observed in about 23% of cases. An example of multiple, multifocal, multicentric bilateral lesions that were revealed with an MRI. So the plan of the operation changed. Other examples of a lesion on the right breast where the second one was not known with ultrasonography or mammography, and in this case, where the largest tumor is near the thoracic wall, and the second lesion was revealed with magnetic resonance. Other examples were contralateral lesions were revealed with MRI, apart from bigger lesions on the right breast. And in this case, many times in these cases, the two cancers are of different histological type. So this changes the operation plan and the chemotherapy plan. In cases of DCIS, where microcalcifications are observed in mammography, an MRI would help to define the extent of the lesion that many times is larger in MRI than in mammography, as we see in this example. Or in this example, I don't know if you can see, there is a little lesion with calcified microcalcifications. In MRI, there was a larger lesions in the left breast, and in a specimen, there were multiple foci of microcalcifications. So there are controversies about how useful is MRI as a preoperative tool. and staging tool, most of the associations recommend not to perform an MRI before surgery. And there are some trials, 2 out of 3 of them, Combis, Monet, and Monet, are against preoperative MRI, and they say that the reoperation rates are about similar, but the third, Bomb, says that the reoperation rate is larger with no MRI, so and preoperative MRI would be useful. But this trial is in younger women with denser breasts. The fourth trial is about BCIS and also doesn't show a significant difference of reoperation rates in MRI and non-MRI group. Meta-analysis about surgical outcomes with and without MRI showed that first-line mastectomy is higher for the MRI group, 16%, than for the non-MRI group, 8%. A similar reoperation rate, 12% vs 11%, and an overall first-line plus secondary mastectomy rate significantly higher for MRI group, 26% vs 18%. In invasive lobular histology, first-line mastectomy rate was 31% vs 25%. The reoperation rate was 11% vs 18%, and the overall mastectomy rate 4% vs 40%. However, even though the American Board of Surgeons say not to perform an MRI before operation for breast cancer, and regardless of evidence and recommendations, a survey showed that 41% of responding surgeons perform an MRI. And another survey showed that surgeons preferred to request MRI in cases of BRCA mutations, familial or personal breast cancer history, dense breast and younger women, axillary nodal involvement, mammographical occult tumor, multifocal and multicentric disease unconventional imaging, invasive lobular histology, triple negative cancer, T2 and T3 stage, candidates for mastectomy requesting breast-conserving surgery, and radiologist discretion. EUSOMA, the European Society of Breast doctors that work with breast, recommend a preoperative MRI to be performed in lobular cancer and BCIS in dense breast in younger women and women that are younger than 60 years with increased risk. If there is a discrepancy in size of 10 millimeters between mammography and ultrasonography, and patients that are eligible for partial breast irradiation. This is an example of a very dense breast where a lesion was revealed in an ultrasonography, but after the MRI, there were multiple lesions of a different imaging that had the enhancement of type 3 care with type 3 cares, multiply bilaterally. A lesion with spiculated margin was revealed on the right breast, and the second one of the left breast. These lesions need to be biopsied before the operation in order a plan to be made if all the lesions are malignant and what type of cancer they were. On the other hand, in women with fatty breast, it is recommended that a good mammography and ultrasonography would solve the problem, and there is no need for an MRI. But in all these cases, a mammography of the specimen is needs to be made. But there are some problems sometimes in a fatty breast, preoperative MRI was not performed. So the women, after some months later, came with a lesion that was revealed to have a KERF3 enhancement and was also malignancy. So you cannot convince a woman that had the surgery that still cancer is within her breast, but she will that will not affect her overall survival. This is difficult. Nowadays, there is a ongoing trial that is called MIPA trial about the preoperative breast MRI. The candidates are in two groups, those with mammography and ultrasound only before operation, and those with contrast-enhanced MRI, and the outcomes are surgical and clinical. The study is waited to be finished in 2023. Till now, there were some results. 50% of these MRI were preoperative, 17% already done for diagnostic reasons. 40% of them are requested from surgeons, more often in younger women and women with denser breast. Surgeons ask for an MRI more often if they already plan a mastectomy. Surgical plan of mastectomy before MRI was 20% in the MRI group and 15.4% in the non-MRI group. The increase of mastectomy after MRI was small, 1%. 73% of patients have had the same operation as planned with no change after MRI. 20.7% had a less extensive operation, and 14.2% a more extensive operation. Also, the lower rates of reoperation was there was a lower rate of reoperation of 13% for non-MRI group to 8.3% of for MRI group, but we have to consider the higher mastectomy group. So from 100 women that had a preoperative MRI, 17 had it for diagnostic reasons, 33 were asked from surgeons, 83 for preoperative staging, 59 did not change therapy, 10 had a less extent surgery, 12 a larger extent surgery, and 2 had a mastectomy, and only 2 had a mastectomy that was not decided. So as a conclusion, we should say that the preoperative MRI is a useful and sensitive tool for finding cancer, but should be performed under evidence-based indications. We wait for the results of clinical trials, especially MIPA, and for give nodes, ultrasonography and fine needle aspiration is a better staging method. Thank you very much.
Thank you very much, Dr. Polou, for your detailed and interesting speech. We only have time for one question. The preoperative MRI scan may lead to better planning for breast cancer surgery, but it can also reduce the need for repeat surgeries. It can also result in overtreatment, though, and an increase in the mastectomy rates, as you said. What guidelines do we have as breast radiologists so as to reduce overtreatment?
Well, we perform MRI if we are asked. We see mammography and ultrasonography. If we see a second cancer, we have to declare it. We can't say there is not. So we only say, but in surgeons, that it should not be performed in all women. It should be performed for some women with indications, with particular indications.
Okay. Maybe the tumor size also, if it's too
yes,
big.
The tumor size, the dense breast, the age of the woman, there are particular indications, and it is necessary in all cases to have a biopsy in order to decide whether a preoperative MRI is necessary or not. Lobular cancer has different indications.
Okay, okay. Well, thank you very much It was a very interesting and concise speech, and everybody for your attention. I would like to pass you on to the next coordinator, Dr. Denise Kolomovi, who is a radiologist and director of Breast Radiology Unit in Via Kliniki in Athens.
Thanks very much, Hiro. Good
You're
afternoon.
welcome.
First of all, I would like to thank the organizing committee for the invitation to be a part and panelist at this session of this today's breast invasion course. We are only at the start of the era of the use of advanced AI methods for breast imaging. The multiparametric nature of MRI has the greatest potential to incorporate AI applications into personalized care, either for screening high-risk patients or by monitoring patients with suspected or proven cancer. It's my pleasure to introduce Dr. Varaki Lili, Director of Radiology Department at Metropolitan Hospital in Athens. She will briefly address to you the clinical significance and importance of AI, more specifically radiomics, on breast MRI cancer screening, detection, monitoring, response to treatment, and pre-surgical planning. Dr. Varaki, the floor is yours.
Thank you very much. Okay, can you hear me? Hello?
Yes?
Can you hear me? Yes?
Yes, we can hear you. We can hear you.
Okay. And in today's talk, I will be discussing breast cancer MRI-based radiomics. Taking a very short stroll down memory lane, we see that in the beginning of the last century, the only tool that the radiologist had for diagnosis was the plain X-ray. This changed significantly towards the end of the century, where new modalities were introduced, such as ultrasound, computed tomography, and of course MRI, which is the most complex of them all. And further advancing these modalities, we now see that we can have a more advanced multiparametric way, especially in MRI, of imaging. And I think that in the future, we will be seeing many more modalities and ways of imaging that we cannot even imagine at the present. We are gradually shifting from a purely structural anatomic imaging to a more functional way of imaging the human body. And this also applies for breast MR. Breast MR now, we are able, and we were not able in the beginning of this century, to perform high resolution structural images, less than 1 millimeter isotropic images, combine them with multiparametric techniques, kinetics, or more eloquent perfusion techniques, diffusion, ultrafast angiographic techniques, very well implemented in clinical routine practice now, and some more techniques that are not so much introduced into the clinical practice, such as spectroscopy. These give us the ability to image have an indirect measure of microvascular density, cellularity, and vascularity, and as metabolic activity. So this is a high resolution, dynamic contrast enhanced MR image of the cancer of the breast on the right. We combine it with multiparametric techniques, such as diffusion weighted imaging, or these very impressive ultrafast techniques that we are using routinely in clinical practice. This can show us the area of infiltration in less than 1 minute. It's a very early enhancement pattern. And we are able now to acquire several imaging biomarkers from these multiparametric techniques. Traditionally, the radiologist uses his eyes to be able to characterize a lesion. And this is a very subjective process, obtaining qualitative information. In order to make this more objective, scoring systems have been proposed. We are all well familiar with the ACR by its lexicon. In order to have a more structural way of reporting our findings, it remains, however, subjective. So we seek the use and the aid of computers, and we are again familiar with the computer-aided detection system, the CAD system. It helps us measure more accurately or detect a lesion more accurately. This is the first step in the use of computers and is a primitive form of artificial intelligence. However, it only detects. It does not characterize our lesion. And if my discussion today was Radiomics MRI breast. What do we use in clinical practice? I would have to stop my talk right here because the remaining of the talk is theoretical. We do not implement radiomics in breast MR imaging in clinical routine daily practice up to date. Now, why do we need and what exactly are we doing with radiomics? I will first have to prove to you the equation image equals data, especially MR image equals huge raw data. Millions of voxels, hundreds of quantifiable markers, they're out there. All we need to do is collect them, organize them, analyze them, categorize them, and extract the useful information. We are in the era of precision and prediction. Image equals data, huge raw data, limitless information, imaging markers, various markers, morphological, multiparametric, and of course the radiomics. This is a cancer. This is a breast cancer on the right. We can see this with our human eye, but we cannot see the limitless information that it hides. And we want to extract this information. The era of prediction and precision is here, and it's also in imaging. We want to be able to better measure and obtain the data and use it with the use of imaging biomarkers in every stage of oncology imaging. And lots of money has been given to predictive healthcare analytics and will be given in the future. So I come back to how do we extract the data from the images? And here the concept of radiomics is introduced and first proposed by a Dutch researcher in 2012. We need computers. We need computers for radiomics, and we need artificial intelligence for radiomics. What is an image? Huge raw data. What are radiomics? Extraction of numerous features from imaging. And what are these features called? They're called phenotypes, imaging biomarkers. And why do we combine it with artificial intelligence? Because we want to extract the useful information. We want to analyze the data. Raw data, quantitative information, useful information, decision-making. And this is extremely useful because we want to combine it with other fields of oncology, such as molecular oncology, with the other omics that are out there, and what is called radiogenomics. So we use all these advanced imaging techniques and add our radiomics and extract our biomarkers, and the end goal is personalized cancer imaging. Going back to our imaging markers, the radiomics markers are numerous and different types. They can be based on size, shape, morphology, and contrast kinetics. This is just an example of some of the radiomics extracting characteristics that we can extract. Some of them are visible, but most of them are non-visible to the human eye. And it is these, the agnostic ones, that are the most important ones. And we categorize them into different orders of statistics. It's beyond the scope of this talk, but you will see in the literature, first order statistics, the words such as entropy, skewness, kurtosis, which is analyzing an intensity of a pixel. Second order statistics, which is texture analysis. This is analyzing the intertumoral heterogeneity. And again, the higher statistics, which combines intensity and textural features into several different patterns. These are very complex processes that are performed by computer statistics. The easy part is that these eloquent, non-visible markers can be extracted by images that we already have. And that's why most of the studies performed are retrospective from data sets that already exist. And we need artificial intelligence. We need machine learning, and even better, we need deep learning neuronal networks in order to analyze this data. So what would a radiomics workflow look like? What do we do in radiomics? This is a breast cancer, and this is our region of interest. We take the data, we segment it either manually or automated, and we transform it into this 3D segmented image. And then we extract our features, whichever feature we selected, use artificial intelligence to analyze the data and use the robust information that we need. And then finally, we put a radiomics signature on this tumor, correlated with other features, clinical and genomic, and come to our clinical endpoint and make a clinical decision. The most primitive form is our CAT system which has today, tumor detection without characterization, quantitative imaging biomarkers radiomics. We use artificial intelligence with processes such as data mining and select the important features, and all of these are decision support tools. So this is our bag of imaging markers. We have all these interesting radiomics features, we use AI, and we come to all these we can answer all these very interesting questions: detection, diagnosis, prognosis, monitoring, and genomics. We're used to these biospecimen samples. We know that we can obtain biomarkers can be related to histology, but now we're talking about imaging biomarkers, anatomic, functional, molecular, and we can either be qualitative, this is what we're used to, and this is what we use in clinical practice, or the future, we can actually use multiparametric markers and even more eloquent radiomics markers to come to our conclusions. And why do we need these imaging markers? They have various advantages. It's a non-invasive way of obtaining a marker. It covers a large area of the tumor. It shows heterogeneity of tumors. It can be repeated as many times as needed, especially MR, it doesn't have radiation. Can be used to monitor a response to treatment. And the only downfall I would say is that it is not yet standardized. So both the biospecimen and the imaging markers can perform a diagnosis, but look at all the advantages if we were able to use these imaging markers: screening, monitoring, heterogeneity mapping, and evaluation of multiple tumors. However, we are not there yet. It's a difficult process. It needs to be validated technically, biologically, and clinically, and it has to be cost effective. So we do know that we use the ACR BioRads and it's used worldwide, but what about if we wanted to use perfusion and a K-trans, for example, to quantitatively image a tumor? We don't have enough studies to prove it. We can use it in single center studies, and we can show that it does show the differences in vascularity of treatment, but it has yet failed to demonstrate value as an outcome measure in imaging breast. We take mammography, we use an MR image, we use multiparametric markers such as K-trans, ADC, DTI measures, and we also use radiomic markers. And we can use these measures in vivo, not in vitro. This is a response to chemotherapy. We can use and select and measure various markers before, during, and after treatment. Again, I say this is very difficult. We need the proof of mechanism. We need to be able to show that there is a relationship between our marker and the actual disease. This needs technical validation, biological validation, comparison to a gold standard, and clinical validation. We need to be able to apply it to a large number of patients. We haven't done that yet. And that, and only that, will lead us to clinical qualification of the measure. So we used our RESIST or our BioRads criteria in the past to measure our lesion. This was very qualitative. We advanced to using multiparametric techniques with diffusion, with perfusion, or whatever else. And now we're coming into a new stage of image, a stage where we will use in computers, which will be performing more complex statistical analysis. And there has been proof that the radiomic heterogeneity of a tumor does correlate with its genomic heterogeneity. This is very important. So we're going from past, future, present. We are in a transitional stage. Our endpoint has to always be precision medicine. The literature shows us that there has been an increased amount of literature out there that is involved with these radiomics and breast and all of the types of human body imaging, especially MR, is increasing in the past decades. We're not there yet because there are numerous limitations. And the more complex the acquisition and the modality and the data, the more difficult it is to obtain reproducible results. MR is the most complex imaging modality that we have. And that is the most difficult. And that is why AI and radiomics is we will see impressive results, but it will be very late in comparison to the remaining modalities. We still have small single center studies, small patient cohorts, only exploratory proofs of concept, discordance between different studies, and of course there remains the big issue of feature robustness and inter-observer variability. We need to solve these problems first. This is the pipeline of the radiomics. We need to have an acquisition that is reproducible and standardized, segmentation that can be automated because we have large data, extraction of features in the same way. We have to be able to teach the artificial intelligence algorithm a method to be able to produce results that are reliable, and of course, reproducibility. We need quantitative, high-resolution, longitudinal standardized studies that can be sensitive to molecular perturbations. Not there yet. One of the main limitations that we have with radiomics and artificial intelligence are our data sets. We need large data sets, we don't have them, and we need high resolution, sorry about the typo, reproducible images that we can use. So the statistical power of our model will be dependent on the image acquisition. We can acquire, MR has a big problem with that, and covariates. And of course, the issue of database sharing. We need to be able to acquire big databases that will have standardized, normalized images. The Cancer Imaging Archive is of course, a big step towards this direction. We cannot use real data. We're using synthetic data because we don't have enough data. And this introduces the big problem of bias. We have another problem is we're using raw data, we're sharing, we're labeling information. The information is out there on the internet now in these shared databases. These pixels now have high value and can very easily become an area of exploitation. Data bias, big issue, beyond the scope of this talk, but data ethics, where does this data belong to? Who does it belong to? Who owns it? I would refer you to the Ethics of Artificial Intelligence in Radiology by the European and North American Multi-Society Statement for further information. In MR particularly, one of the problems is the data set shift. So this is an MR image. This is what the computer sees. And each machine has its own fingerprint of pixel patterns. You can imagine what happens there. We see, the radiologist sees this tumor, but the machine sees an aggregation of pixels. We need to have computers that it can reliably extract the features from the pixel data.
High performance technique?
Excuse me?
If I wanted to say the limitation of the vacuum assisted biopsy in a small breast and depletion depends of the performance of the radiology ability
of the radiologists.
I'm sorry, I can hear somebody else in the background. Can you hear that?
skill of the radiologist's skill.
Computers extract features from the pixel
doing the
images,
talk in my mind.
and we need standardized protocols. If we are using 1.5 Tesla or a 3 Tesla, different vendors such as Philips, Siemens, Toshiba, or the protocol of acquisition, and in MR, there are various protocols of acquisition. This will all affect, especially noise. If we introduce a small amount of noise into our algorithms, we can have completely different results. A panda can be perceived as a gibbon. And also the artificial intelligence problems. It's beyond the scope of this talk, but we have to be able to explain what the artificial intelligence algorithm is doing, how it's doing it, and what it's based on. That's why radiomics markers are still at the lowest level of evidence. MRI breast and radiomics, it can be used in every stage of oncology, detection, diagnosis, prognosis, monitoring, and radiogenomics. There are several reviews. The latest one in 2020, again, showing us the vast amount of literature that is out there. And there's a lot of literature out there. Most of the studies are interested in breast lesion classification, the ability of radiomics to distinguish between benign and malignant lesions. The studies are small, they're retrospective, they're mostly using dynamic contrast enhanced imaging and to a less degree diffusion rate in T2 images. They're using every type of radiomics features. This applies also for prediction of lymph node metastases. It has been used to predict different molecular subtypes, or sorry about the typo, to predict the response to neoadjuvant chemotherapy, or to predict survival outcomes. It's interesting to see that the studies all use different types of phenotypes, different types of imaging markers. Some studies use one marker, some studies use up to 99 markers or more. The results in most of the studies, if you take them one by one is good. There's area under the curve from 0.8 and 0.98 in answering the question at hand, but they are single study, small studies with one center. They cannot be applied in clinical practice. And this is interesting here that there was one that was trying to correlate radiomics features with disease-free survival, and they came up with a RAD score using 156 different phenotypes. Good results, one study. So if I was to say what our future is, well, I will just make a prediction here. The radiologist is sitting at his desk and he has all these computers, he has his prior images coming up, the radiomics phenotypes automatically sent to a database. And with the help of artificial intelligence, the data, we're making some sense of the data. And we are actually, in the end, trying to give a radiomic signature and answer whatever question we have: diagnosis, prognosis, response to treatment, or recurrence. And some studies are also already underway, and we will see many more of these in the near future, trying to improve breast cancer diagnosis by the use of artificial intelligence or radiomics. We're not there yet. The future, the imaging of tomorrow, radiomics combining artificial intelligence, combining multiparametric imaging in a more quantitative approach with the use of imaging markers. So I think that I showed you, I hope that I did, that breast MRI images are more than pictures, data. And that by combining our multiparametric imaging, radiomics, and artificial intelligence, we have the potential of increasing diagnostic accuracy. We have the possibility of unlimited implementation in imaging. It's a non-invasive way to characterize our entire tumor or multiple tumors and combine with other omics, radiomics signature. We can call it a type of virtual biopsy with all the advantages of not of the virtual part. And I think that we should acknowledge it's still a research stage. It has not been implemented in our daily practice because of lack of knowledge of these new entities, lack of protocol standardization, data set. We have to solve the issue with the databases, and of course we need more trials. However, we are in the era of personalized medicine, and I think that precision and prediction and imaging can play a significant role in this. Thank you very much for your attention.
Dr. Baraki, first I would like to apologize for the annoyance with the interference. I would like to thank you for this wonderful, exciting presentation, and quite comprehensive as well, which enlightened the role and potential of MRI-based radiomics in establishing a strategy for patient treatment and care. Just a brief question. By chance, have you any experience by applying radiomics markers such as entropy or other indexes to have strong association with different subtypes of breast cancer?
I don't have any experience with different breast types, but I have applied kurtosis for the response to neoadjuvant chemotherapy with exceptionally good results.
Thanks very much. That's a very good point. I would like to hear it for the new radiologists to take home measures. I'd like to open now the Q&A session for discussion, inviting Associate Professor of General and Breast Surgery, Kontos Michalis, at University of Athens, like a hospital, but I'm not quite sure. Oh, that's Dr. Katsaros. I wasn't quite sure why he was made it. And Dr. Katsaros Vasilios, consultant radiologist, director of the MRI department of advanced imaging modalities at General Anti-Cancer and Oncological Hospital at IS Savas in Athens. I'd like to address two questions to you, just to warm up the audience, one for Professor Kontos and the other for Dr. Katsaros. Professor Kontos, which would be the target group of patients that you suggest should undergo preoperative MRI? And the other question for Dr. Katsaros is, what MRI sequences would you suggest for best tissue detection and characterization, and if diffusion on its own provide adequate information for grading detected lesions? The floor is yours for discussion and comments.
Should I try to answer? Can you hear me?
Yes, we can.
Sorry, so I will try to answer about when we ask for a preoperative MRI scan of the breast. That's a good question with no consensus on the answer, I'm afraid. And this is reflected to the different guidelines we have from different scientific societies, if you want. I have to say that in comparison to 10 years ago, MRI is becoming, in the everyday practice, more and more is becoming more part of the everyday practice. Generally speaking, patients who will have, who are having or who are going to have preoperative chemotherapy, we would like to have a very good way of mapping or of, of mapping the breast and how the tumor is responding or not to chemotherapy and the axilla. Second, we would like to have MRI scans for patients who have dense breasts, and we feel that the more traditional means of imaging, mammograms, ultrasound scans, do not tell us the whole truth about the extent of disease. So we need to know how big is the disease. I think this is the main two indications in the everyday practice. And then with regards to the people who are having MRI for screening, that's again a difficult question. In order to be sure that the screening tool is worth it, it is not only the accuracy of the actual tool we use, the only criterion we have. It's much more than this. It is the cost. It is why, it is whether the disease we're trying to detect is treatable, and is whether the early diagnosis of a new cancer is reflected or has a result, a better benefit, a better survival benefit. So, which is not always the case. So I think, to wrap it up, two main indications, I repeat, main indications for preoperative MRI scans, which is the picture we have about the cancer is not clear on mammogram and ultrasound scan, lobular cancers, young dense breasts, young women, etc., etc. And second, neoadjuvant chemotherapy, where we want really to follow how the cancer reduces because of chemotherapy. And about screening MRI scans, MRI mammography, that's a difficult question. We heard Dr. Panizza's presentation and the details about the DENSE trial, a good trial, but in the very early days still. We only have the 2 years result of this trial, and we're waiting for more information from this.
Thank you, Professor Kodos.
So good afternoon also from me. I haven't heard because it was interrupted the question.
No problem. I'm going to go through it again.
About diffusion and perfusion or what?
Yeah, that's right. What MRI sequences would you suggest for best tissue detection and characterization? And could diffusion or perfusion provide adequate information for grading detected lesions?
Okay. So at least according to the state-of-the-art one paper that is published in Radiology last year, the better, although they're not standardized, the better sequences that you could use is just simple diffusion weighted imaging with p-value of 0 and 700, and also the ultra-fast dynamic contrast enhanced MR imaging. There are also some other sequences as the restricted spectral imaging, diffusion kurtosis, which is some post-processing, and I think Dr. Varaki mentioned that, as also the intravoxel incoherent motion. So these are too many data, as Calliope said, and we need too much time. It's time consuming, so that we can extract, even in human intelligence, all the information that can help in preoperative imaging of breast, as well as in follow-up of after chemotherapy or after surgical removal of the lesion. So to summarize, diffusion has many branches, and till now only the simple diffusion is taken the most part of the diffusion imaging. There are many papers out there for intravoxel coherent motion and restricted spectral imaging. So in our department, we are using the ultra-fast dynamic contrast enhanced with resolution. It's a temporal resolution of 4 seconds. So in the first 20 seconds after the enhancement of aorta, if we see a wash in and wash out, there we have the probability that we have to do with the cancer. And also there is restricted spectral imaging, which is post-processed to also diffusion kurtosis and the simple diffusion imaging and ADC and so on. But in some cases where there are equivocal findings, then we use also intravoxel incoherent motion, where we can detect the microvascular diffusion.
Thanks very much for the valuable tips. I think that the take-home message would be the field of radiomics is rapidly evolving. Standardization of the methodologies used in the radiomics workflow is essential towards clinical implementation. Radiomics, such as the need to incorporate subtypes and clinical information into the analysis. AI has the greatest potential to increase performance, reduce time of diagnosis, increase sensitivity and specificity of breast MRI, and therefore become a continuing journey towards best patient care. Honestly, it was a great session. I really enjoyed. I would like to thank our outstanding speakers for their efforts, as well as their organizing committee once again.